just to continue seeing patients. But I'm delighted to be here. I also have lots of Allegheny County connections. So my father grew up in Pittsburgh. Um, he went to Pitt. My sister went to Pitt to study. I lived in Pittsburgh for a number of years and worked at the university. My wife went to graduate school in Pittsburgh, and I've been back several times. It's amazing. Every time I go back, the city, the landscape, it's just changing constantly. And sometimes I don't even recognize the city. So today, rather than give sort of a comprehensive talk on childhood lead poisoning, I thought I might instead just try and answer some of the common questions I hear from parents about lead. Some of these questions I hear that come up sort of just in my general pediatric practice, and other of these questions were more common as I was taking care of kids with really high lead levels in Boston. And hopefully we'll have some time at the end of the presentation to answer questions. Here are my learning objectives. A lot of these I'm going to start with just giving kind of a background about lead poisoning, and then many of these learning objectives we can also should be answering through some of the common questions as they come up. And so the goals will be to sort of define childhood lead poisoning, understanding the epidemiology of lead poisoning, understanding the toxicology of lead poisoning and why kids are uniquely susceptible, understanding the routine screening recommendations for lead, and then listing strategies for counseling families on how to limit their exposure to lead and how and when to make referrals to local and national resources when indicated. So before we actually define lead poisoning, I think it's first important to understand how we test for lead in the body and what that number, sort of that microgram per deciliter number, actually truly represents. So it's important to remember that the presence of lead in a child's blood is an indicator of sort of past or current exposure and absorption, but there are limitations in how we interpret individual results, right? So when we obtain a venous lead level, what we're really measuring is the lead content in red blood cells. It's not a measurement of lead in the plasma. And lead in the plasma is actually the more problematic sort of measurement of lead, because lead in plasma can really very easily move to adjoining cells and adjoining tissue, whereas lead in red blood cells just sort of stays in the red blood cell. So I think the venous lead level, as I think of it sort of as being an imperfect proxy for the lead residing in the cells of the organs and tissues, the sites of where the majority of toxicity actually occurs. You can also think of it in a slightly different way too. It's really a measure of potential toxicity based on blood lead levels correlation with various health outcomes and studies of large kids. So all of that to say is that sort of the current lead poisoning intervention level, which is 3.5 micrograms per deciliter, is really based on epidemiology, not true toxicology. So the CDC, I know this is probably a review for most of us, but the CDC announced in 2021 that it was lowering its blood lead reference value from 5 to 3.5 micrograms per deciliter. And I'm including the table on the left and the graph on the right to really show how the CDC has used a variety of language and definitions for interpreting children's lead level over time, beginning in the 1960s. It wasn't until we can see that in the 1970s, a blood lead level of 40 was considered to be quote unquote undue or increased lead absorption. And it wasn't really until 2012 that the CDC began to use the terminology of reference value into its language. So oftentimes we hear the question of where does this blood lead reference value come from? So it is a statistical number that's based on data collected from the National Health Examination and Nutrition Survey that's done data is released. It's done continuously, but data comes out every 2 years. And it's based on the 97th and a half percentile of the blood lead distribution in US children aged 1 to 5 years of age. So 97.5% of kids sampled fell below that 3.5 microgram per deciliter threshold, and 2.5% of kids fall at or above that level. There's about 22.5 million US children under the age of 5. And so about 550,000 kids are above this blood lead reference value, if that makes sense. The blood lead reference value is not a health-based threshold or a safe level, right? It does not represent a level below which there is no harm. Rather, it is simply a screening benchmark to help flag kids who are potentially at higher risk than typical blood lead levels and may benefit from further public health interventions. To complicate things perhaps even further, state and local public health agencies often adopt their own definitions and languages regarding thresholds and action levels for what they constitute lead poisoning or elevated blood lead level to be. So here in Pennsylvania, a blood lead level of 20 or above, or a level of 15 to 19 measured on 2 separate occasions is considered to be lead poisoning. The lead laws as they relate to screening, enforcement, abatement, landlord regulations and tenant protections tends to vary from county to county in the state of Pennsylvania. Clinicians and public health organizations should really familiarize themselves with the blood lead level that triggers health department interventions and case management in their county. I know that in Philadelphia and Allegheny County, a lead level of 3.5 or above should trigger a home inspection and case management services. That often includes education and so forth. Before we jump into some of the common questions, I thought we'd start on a note of optimism. In many ways, I feel that we've been way too effective with our there's no safe level of lead messaging. And sometimes the stress of that, particularly for parents, can be more harmful than the lead itself. And so as clinicians, as public health workers, as anybody really advocating on behalf of children, it's important to recognize that, yes, we want to work together to keep lead exposure as low as possible. We want to support legislators and agencies who support lead surveillance, reduction, and response programs, while also recognizing that we've come a long way in improving the lead health of our communities. And with good diet and sleep and the promotion of healthy brain development, children can be healthy and happy, even if they have elevated lead levels. Okay, so first question, how much lead is dangerous for children? It's important to remember that lead is neurotoxic even at low levels. So low level elevations in lead, even below the reference value of 3.5 micrograms per deciliter, can lead to irreparable decrements in cognitive function, which oftentimes in scientific studies is measured in IQ loss and academic performance achievement levels. So looking at these two examples here, if you take a child and they go from essentially a lead level that's undetectable to 10 micrograms per deciliter, we see on average about 6 IQ points lost. If that same child then goes up to 30 micrograms per deciliter in lead, you see about 9 IQ points lost. And so we can see here that most of the harm happens actually at the lowest levels, right? So this highlights the nonlinear relationship between blood lead concentrations and cognitive effects. You see steeper IQ losses at lower levels of exposure. Studies of brain size and metabolic activity show differences in part of the brain involved in memory, learning, and behavior in young adults with early childhood lead poisoning. It's not just IQ that tends to be affected, right? So high blood lead levels can result in behavioral problems in children, most commonly things like inattention, impulsivity, and aggression. There have been some studies linking lead to things sort of antisocial behaviors like oppositional defiant behaviors, conduct disorder, delinquency, and even criminal behaviors. So really the takeaway here is there's no safe level of lead exposure. I think this graphic is actually a great example of sort of what we call in epidemiology the paradox of prevention as it applies to lead poisoning. So this is a concept of sort of preventative health that says that when you have large numbers of people exposed to small risks, you often generate many more cases of harm than a small number of people exposed to a very high risk. So as this relates to lead, we can see here that the majority of IQ points are actually lost in the public at very low levels of lead, at levels below, at the time that this graphic was made, below the reference value of 5 micrograms per deciliter. So again, this argues for, we don't do a great job of this, and I'll keep talking about this throughout, but it argues for really a more universal and primary preventative approach to lead prevention in our communities, rather than a responsive secondary approach, which is what most of our public health interventions focus on. Is my child going to be developmentally delayed or have behavioral issues if they're exposed to lead? My resounding answer to this question is no, absolutely not. So the effects of lead on any individual child's cognitive or behavioral development is entirely unpredictable. An elevated lead level should be really thought of as a risk factor for neurodevelopmental problems, but it is not a diagnosis. When I was taking care of lead exposed and poisoned children in Boston, I think something that was often very reassuring to families was sort of sharing my story with lead. And I grew up in a 19th century home in New Jersey where there was lots of peeling and chipping paint in the 1980s. And I was exposed to lead as a baby. And the doctor who was running the lead clinic before me also had lead poisoning as a baby. And so I look to myself as an example to families like, your child can go on to be a doctor or a teacher or a productive citizen despite being exposed to lead. So I think that was useful for a lot of families and very reassuring because what you find online and oftentimes when we talk about lead, it can be very stigmatizing. So I think about the prognosis in terms of both risk and protective factors, including a whole host of environmental factors. So things like healthy developmental stimulation, high quality preschool, and the sort of the nutritional status of the child. And then I think there's also a lot of genetic factors that may lead to one child being more impacted than another that we're really just beginning to understand and ask questions about. I often recommend that parents focus on those factors that are within their control, especially with regard to nutrition and educational enrichment. The ways that I like to think about nutrition is that deficiencies in essential vitamins and minerals tend to increase toxicity and decrease treatment responses in terms of thinking about chelation and that sort of thing for kids with high lead levels. But we know that when lead is absorbed in the duodenum, the most distal part of the small intestine, it competes with other cations. So these are elements with 2+ charge, calcium, iron, zinc, magnesium. And so if you're deficient in those vitamins, in theory, lead will be more easily absorbed. Whereas if all of those ions are sort of fully bound in the receptors, then they will be potentially prevent lead from being absorbed. I often do a lot of counseling with families about just healthy diet and making sure they're getting a diet that's rich in iron and calcium and vitamin C and vitamin D and zinc and magnesium. We'll often screen children at 1 and 2 years of age for iron deficiency anemia. And certainly we check blood counts in kids with lead exposure to make sure there's not concurrent iron deficiency anemia. And we will supplement children who truly do have iron deficiency. In terms of the educational enrichment piece, I really focus on the basics here with families, right? Lots of reading, talking, and singing to children, lots of stimulating play with books and puzzles, and really trying to keep screen time to a minimum. In terms of referrals, in the state of Pennsylvania, all children with a history with a high lead level are eligible for early intervention evaluation. At least many of these kids won't qualify because they're meeting all of their developmental milestones, but they are eligible for evaluation. And so I absolutely refer all of these children to early intervention. There's no downside to doing that. It's important as these kids get older to watch for emerging difficulties at critical transition points in their education. So I think about things like first grade, fourth grade, and then as they're around seventh or eighth grade as well. And then watching for behaviors that might interfere with learning. So things like inattention, distractibility, impulsivity. Okay, this is a fun table. So another common question that we hear is, should my child be tested or screened for lead? This can be confusing for many families and even clinicians because the guidance sort of varies depending on the source that you're getting your information from, whether it's the American Academy of Pediatrics, the Center for Disease Control or Prevention, or federal or state regulations. This is a super busy image of what we call the periodicity schedule from the American Academy of Pediatrics. And it's a complete guide to preventative healthcare from birth up until 21 years of age. Lead screening is included here somewhere in the middle of this first column. But literally this includes everything from when to screen for blood pressure in children, vision and hearing screening, screening for things like autism and depression. The current American Academy of Pediatrics recommendations is that a lead risk assessment be done beginning at 6 months of life, and then again at 9 months, and then again at 12 months, and 18 months, and 24 months, and at 3, 4, 5, and 6 years of life. The recommendation here is to do a risk assessment. So that's performing some sort of lead screening questionnaire. And then if that comes back positive, consider testing. This is problematic for 2 reasons. One is that the evidence as it relates to the benefits and harms for lead questionnaire screening is really lacking. And lead screening questionnaires are notoriously not accurate for identifying kids with elevated lead levels. One of the questions on the questionnaires is, do you live in pre-1978 housing? I will tell you from my experience that most families have no clue when their home was built. So the questionnaires are really inaccurate and largely unhelpful. Screening is required for all Medicaid insured children nationwide at 12 and 24 months of life. So I will tell you that in my practice here at CHOP in South Philadelphia, we take care, our patient population is about 80% Medicaid. So we just screen everybody. We consider just everybody to be high risk. And so we check a lead level at 1 and 2 years of life, and more frequently if it's high. Medicaid eligibility is thought to be an independent risk factor for lead exposure. And so that's why we screen all of these children. For children who are not enrolled in Medicaid, requirements for lead screening vary by state, and in some cases, county by county, such as the state of Pennsylvania. Some states, such as New Jersey, have universal lead screening requirements. If you're uncertain about screening requirements where you live, you just want to contact your state or local health department to have that question answered for you. Ideally, in my opinion, universal testing would be required for all kids at 12 and 24 months of life. In terms of method for screening, ideally, we recommend that a blood lead venous level be used as sort of the gold standard for testing and screening. Capillary lead screening definitely is a suitable method, but can certainly overestimate the lead burden in blood lead due to contamination from the surface of the child's skin or even just from the sample collection process. Elevated capillary lead levels should always have a confirmatory venous lead level done relatively quickly within a month or two, depending on how elevated it is, to confirm that it is not falsely elevated. Next question. I've heard lead can be stored in bones. Do doctors ever test for that? The short answer here is no. Before we dive into why we don't routinely test for lead in bones, I think it's best to understand sort of the biology of lead and how it moves through the body. So fortunately, when a child ingests lead particles, only a fraction is actually digested and absorbed, right? So the amount of lead absorbed after being orally digested depends on many factors, but most importantly, perhaps, is the age of the child and how full their stomach is at the time of ingestion. Kids who have a full stomach are ingesting much less or are actually absorbing much less lead than children with an empty stomach. And younger kids under 6, particularly kids around 1 to 2 years of age, just in their gut, they absorb much more lead into the bloodstream than older children and adults do. Once lead is absorbed, blood is the initial receptacle, more specifically the red blood cells. From the red blood cells, it begins to leak into the blood plasma, and then it travels to mineralizing tissues, right? So think about bones and teeth. And then it also travels to soft tissue as well. So muscles, the brain, the kidneys, the heart, the lungs, etc. Because the blood-brain barrier is not fully developed until around 6 years of life, kids under 6 are more vulnerable for sort of the neurotoxic effects of lead. For those not familiar, the blood-brain barrier is sort of a protective layer of cells that lives in the blood vessels in your brain and almost acts as gatekeepers, keeping out harmful toxins and bacteria. And this is not fully developed until kids are about 6 years of life. So in children, lead tends to accumulate in bone, undergoing the greatest rates of mineralization at the time of exposure. So these are often the long bones of the arms and the legs. These bones act as storage sites, as I said, and slowly over time, lead can be released back into the blood, particularly during rates of high bone turnover. So think about growth spurts during adolescence. Think about after during healing after a bony fracture, and during pregnancy when you have quite a bit of bony turnover and mineralization happening. So bone x-rays can show evidence of heavy chronic exposure to lead, but they're neither sensitive nor specific in detecting lead poisoning. And for the reasons that we don't, and that's largely the reasons why we don't recommend it. You can sometimes see sort of what we call these lead lines, which are dense bands of bone, generally seen at the end of long bones. But this finding is something we only see in kids who have a really high lead burden. So kids who have high lead levels and that have been exposed to lead for a long period of time. So most children actually with high lead levels won't have any findings on X-ray. So I would say that X-rays have limited clinical utility in the sense that if we get an X-ray, it's rarely going to change how we manage that patient clinically. And you can't discount the radiation exposure. Although radiation at these doses is quite low, it is something to consider, especially when we have safer and more accurate alternatives such as blood lead testing. I do want to mention quickly that there are certainly adjunctive testing that we do consider in some cases of high lead exposure. So one is something called a protoporphyrin level that we can see here on this sort of graphic on the right. So this is a substance that can build up in the blood when the body is having a hard time making red blood cells. So lead levels greater than 20 can impact red blood cell production, specifically heme production. And so you have a buildup because in this sort of pathway that we're showing here, high lead levels impacting red blood cell production, you have a buildup of the precursor metabolite protoporphyrin. So this will go up in cases of high lead exposure and in cases of levels particularly above 20. And so sometimes it can help us identify those children with chronic lead exposure. It can also be elevated in cases of really severe iron deficiency anemia. So it's not necessarily the most specific test to do, but it is an adjunctive test that we sometimes recommend. Another test that we sometimes recommend is x-rays of the abdomen. So in kids who were concerned of having acute ingestion of lead, like the child who was observed eating a paint chip or swallowing a piece of jewelry that we're concerned has a lead component in it, or children with lead levels above 25, the typical recommendation is to get an abdominal x-ray to look for opaque foreign bodies. In that cases, it sometimes will change management in the sense that if it's proximal to the small intestine, meaning it's at a level in the stomach or proximal to the duodenum in the small intestine, we will sometimes essentially put a nasogastric tube in the child and wash out their GI system to help get rid of that lead exposure and prevent it from hopefully absorbing into the gut. We also, as I mentioned previously, we will often get a complete blood count and iron studies to look for concurrent iron deficiency anemia, which is a common comorbid condition of lead poisoning. Next question. How can my family prevent lead poisoning? So this is, I'm sure, a question most of us have heard before, if not asked ourselves. And so I'm going to focus on here the guidance that applies to most families, regardless of the specific home environment, right? So there are cases when kids test positive for lead and they have a home inspection, and you can really, figure out one or two areas with, that may be causing the exposure, and then provide really specific guidance on ways to keep the home lead safe in that case. But regardless of whether a home inspection was done or not, this is pretty much universally true for all of us. So washing hands and toys often and before eating, right? Kids who are 1 and 2 years of age, everything goes in their mouth, right? Toys, their hands, everything. And most kids are exposed to lead through lead contaminated dust. And so we really want to be washing their hands frequently with soap and water, particularly before mealtime when they're definitely going to be putting their hands in their mouth, and then cleaning like their books and their toys a couple times a week as well, because we know that ends up in their mouth as well. Leaving shoes and dirty clothes at the door. So this is really important. In Philadelphia, we know that there's plenty of lead in the dirt here. And so we don't want families, and in the dust outside. And so we don't want families bringing that into the home. This is particularly important for families, for parents who work in high-risk occupations for lead exposure. And when they bring that lead from the workplace to the home, we call that take-home lead, right? So think about the father or mother who works in construction or plumbing or anything really in the transportation industry. It's really important. Take your work boots or your work shoes off at the door. Take off your clothing, put it in a separate cycle in the washing machine before you pick up your child and hug them. Super important. Damp, clean, wet mop, and damp dust. So sometimes we think about, vacuuming as potentially, or just like dusting as potentially kind of blowing that lead contaminated dirt around rather than getting rid of it. So wet mopping the floors and wet dusting using a clean towel on surfaces is really important, particularly high touch surfaces like windowsills, around the door jambs, that sort of thing. This is good not just for lead, but really for lots of environmental toxins. So think about like PFAS and microplastics. A lot of these things blow into the home and end up on the floor. Um, Creating barriers to possible lead paint and other leaded items. So oftentimes when you get an environmental history, there is some peeling paint around the windowsills or the door jambs or the porch. And so sometimes it's putting duct tape over the area or contact paper as sort of temporary remediation until somebody can come in and repaint over it safely. Sometimes I'm telling a parent literally pushing a dresser or a coffee table or a bed in front of an area that's definitely peeling, simply just to keep the child away from it, from putting that peeling paint in their mouth. Keeping windows closed. Again, this is particularly true if there's construction happening on the block. We know that through like demolition, renovation, construction, all of that can through sort of just natural wind cycles can end up again in the home, on the windowsills, and in your child's mouth. So keeping windows closed. And then eating a well-balanced diet, as we talked about earlier, a diet rich in calcium, iron, magnesium, vitamin C, and D, right? You need vitamin D to absorb calcium, and vitamin C actually triples the absorption of iron. And so I always recommend that when kids are eating iron-rich food like proteins, having some fresh fruit with it will actually increase the amount of iron that the body is able to absorb. I might also add here the importance of safe renovation practices. So when families are talking and telling me about DEI home renovation projects that they're doing, I often just talk about how this can potentially create lots of new lead risk exposures that are going to put their child at increased risk for lead. So whether it's an abatement project that a family is embarking on, or renovating a kitchen or a bathroom, I remind families about the importance of hiring lead-safe contractors. And I also remind families that it's important that the child not reside in the home while the work is actually being done. When I was in Massachusetts, actually, the city of Boston actually had free online led safe renovation training programs for adults and parents who were interested in doing some of the abatement work themselves, or just sort of renovation on an old home themselves, to do it in a safe way, which was really neat. I don't know if that similar sort of program exists in Pennsylvania. In hindsight, I don't think it's surprising that we saw increasing rates of lead poisoning during the COVID pandemic, in part for this exact reason. We saw kids spending a lot more time at home, and parents taking on a lot of renovation and DIY home renovation projects, all of which were leading to more kids being exposed to lead. Next question. Are certain children more at risk than others for lead exposure? Absolutely. So we know that the peak blood lead level tends to be at about 2 and 3 years of age, for a multitude of reasons, but mostly because of sort of peak non-nutritive hand-to-mouth behaviors, right? And also increasing mobility. We see this child here on the left exploring his environment, and the windowsills, we can see a really common place where you have lots of deteriorating and cracking paint that kids get exposed to. Poverty is an independent risk factor for lead, probably because of substandard sort of housing quality, substandard housing. Living in older housing we know living in pre-1978 housing is a risk factor for lead exposure. Belonging to minority race, ethnicity. Yes, being Black or brown in this country, unfortunately, means being at higher rates for lead exposure, and not just lead, but really lots of polluting toxins. Rates of asthma are much higher in Black and brown children than they are in white children. They're higher in children that live in the city than they are in kids who live in the country and the suburbs. Immigration is an independent risk factor. A lot of children who are particularly coming from the developing world, these countries have much less strict or no environmental regulatory laws at all. And so they're at risk for exposure in their home country. But similarly, they're at risk once they've resettled, because we know that many immigrant families tend to resettle in urban, older housing. And so it's often recommended that pediatricians not just check a lead level on a newly arrived immigrant child, but also checking it several months after they've resettled, just because we know they often live in substandard housing. Developmental delays and autism are risk factors. Children with autism tend to have increased hand-to-mouth behaviors. So that's one behavior that might explain this risk factor. Another is that children with autism tend to have lots of oral aversions and sometimes feeding issues that can lead to nutritional deficiencies. Think about iron deficiency anemia, right? So we know that nutritional deficiencies put you at higher risk for lead absorption. Also, kids with autism tend to not respond as well to treatment. So kids with high lead levels and autism tend to have more difficulty taking chelation therapy. And so oftentimes their lead levels are come down at slower rates than kids who are neurotypical, for example. And then pica symptoms, lastly. So pica symptoms, pica is a habit where you're eating non-nutritive objects, non-food objects. This is normal development in younger children. In older children and adults, it's a symptom that we commonly associate with iron deficiency anemia and can lead to higher rates of lead exposure through eating dirt, for example. I think I wanted to talk a little bit about environmental justice as being, we just talked a lot about poverty and racial minority as being risk factors for lead exposure. And so I think I'd be a bit remiss not to talk a little bit about environmental justice. And so quickly here, the Environmental Protection Agency defines environmental justice as the fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policies. Environmental injustice, on the other hand, this is the inequitable and disproportionately heavy exposure of poor, minority, and disenfranchised populations to toxic chemicals, contaminated air and water, unsafe workplaces, and other environmental hazards. Communities, or rather, as I was just explaining, lead exposure is not equal for all children. Low income and minority kids continue to bear a disproportionate burden to exposure, primarily through contact with deteriorated lead paint in homes, in old homes. Communities of color can also face far greater risks due to this legacy of redlining, historic racial segregation in housing, and reduced access to environmentally safe and affordable housing. Moreover, polluting industries are more likely to reside closer to these same neighborhoods. So we call this fence line communities, and this poses additional risks. These environmental health disparities are not limited to lead. So as I was mentioning earlier, the CDC estimates that about 5% of American children have asthma. In Philadelphia, about 21% of children have asthma, and non-Black and Hispanic children have hospitalization rates for asthma that are about 5 times higher than non-Hispanic white children. So Philadelphia, the city where I live and practice, is the second poorest large city in the country with a poverty rate of just under 20%. We formerly held the #1 spot, but were recently overtaken by Houston as being the #1 large city with the highest poverty rate. Philadelphia is also unique in that it has a very high proportion of homeowners compared to renters. And so high poverty and high home ownership rates taken together often means that poorer homeowners lack the funds or may lack the funds to maintain and make the needed repairs to their homes, leaving their families at higher risk for a variety of health-related issues. Two examples just being lead and asthma that we're talking about. In 2021, researchers at UPenn used geospatial tools to show a clear connection between demographic factors like rates of childhood poverty and Black population rates with elevated lead levels in kids under 6 years of age. And so here we are looking at a map of Philadelphia by zip code. And so these dark blue areas in each of these 4 quadrants have low rates of lead poisoning. And then the areas of red have really high rates of lead poisoning. And then there's sort of a scale down with like sort of pink and gray, kind of those shades in between having intermediate levels of lead poisoning, percentage of elevated lead levels in children under 6 years of age. The variably sized black dots represent demographic data. So the larger the black dot is, that equates to higher percentage of that demographic. So the outcome from this study in 2021 that I really want to highlight shows a clear correlation between children living in poverty, owner-occupied housing, demolition rates, and being Black with elevated lead levels in kids under 6 years of age. So I thought this was really interesting. Large correlation here. The recognition that predominantly Black and minority neighborhoods endure this kind of disproportionate share of health burdens is not new. I like this quote that was said over 100 years ago by the Black scholar and activist W.E.B. Du Bois, when he recognized this exact same phenomenon, that Black and brown people in Philadelphia specifically were living in the most unhealthful parts of the city, in quotes. What resources are available to help families? So the U.S. Poison Control Center is obviously a wonderful resource. This is staffed by toxicologists, nurses, and pharmacists 24/7. It's a resource I tell all of my families about, and I often recommend that they keep that number close to them at all times. This is a number that should be hung on the refrigerator. In the event, and just calling that number in the event of any sort of potential exposure, including lead. They're fantastic. Obviously, I always consult with your child's healthcare provider if you have any concerns for lead or other environmental health exposures. Similarly, your public health department should have some good information as well. The PESU, I don't know if everyone's familiar, but the Pediatric Environmental Health Specialty Unit. This is a regional network comprised of pediatricians and public health workers knowledgeable in pediatric environmental health who provide consultation, just checking the time here, on reproductive and children's environmental health issues that affect families and communities on a wide range of topics. You can see this map here. Divides it into regions. So I used to work in Region 1 that was based in Boston. They do also a lot of work educating health professionals and the public. And I'd recommend that everybody just sort of go to the website and just kind of explore really it's such a treasure trove of information. It's really wonderful. Common issues that we discussed when I was working there and that we're educating public on and families on were things like safe cleaning products, exposure to wildfire smoke, lead, exposure, of course, mold, PFAS, pesticides, arsenic exposure, asbestos. I mean, really the whole gamut. It's a wonderful, wonderful resource. I'd also like to shout out my friends in New Hampshire who have come up with this wonderful, this is from the New Hampshire Department of Public Health, this wonderful book called Happy, Healthy, Lead-Free Me. It is a way to not only promote early literacy for families, but also has lots of wonderful lead-related anticipatory guidance for families that are embedded in the pages of this as well. And I think you can scan this QR code to request free copies as well. Okay, very briefly. So much of what we've discussed here, this is my last slide, but much of what we've talked about is lead poisoning and management in the context of secondary prevention, right? So that is, a patient screens positive for lead, how can we mitigate harm and limit ongoing exposure? So primary prevention as it relates to lead exposure really involves educating families about the risks of early prevention from happening. And so as pediatricians and public health professionals, we can do a much better job of providing anticipatory guidance, really beginning at the prenatal visits, and then doing a better job also during those early infancy visits, those well-child visits, talking about lead prevention before the child is mobile and potentially exposed. Much of my clinical focus and research focus is on this issue of primary prevention. In Massachusetts, we initiated something called the Take the Lead on Lead pilot project. So the aim was to test the feasibility of a telemedicine model for preventing and managing low lead level exposure in kids under 6 at 2 academic medical centers in Boston. So at Boston Medical Center, where I was working at the time, and at Boston Children's Hospital. So patients under 6 with a lead level between 1 and 9 were recruited and referred to this program by their pediatricians with the goal of improving early secondary prevention of lead. So these children had low levels of lead, but at the time in Massachusetts, they were not eligible for public health interventions because in 2023, the city of Boston did not inspect homes or provide any sort of case management unless the level was 10 or above. So that's why we chose 9 as being the cutoff. So essentially our intervention was we did virtual visits of the home, which was basically an inspection that the families used using their smartphone, where they took us around their home and gave us a tour, and we focused on those high touch areas, high friction areas like windowsills and door jambs and porches. And based on our inspection, which typically took about 15 minutes, and obtaining an environmental history from the family, understanding what the family did for work, if there's any international travel, if the child spent significant time elsewhere, we provide individual counseling to families on ways to keep the home lead safe. And we also provided families with educational material and what we called lead kits. So we mailed them these kits that contained lead swabs so they could swab those areas of concern in the home and get real-time feedback about whether there was actually lead in the sort of the dust there. We provided families with cleaning supplies, like lead-specific cleaning reagents, gloves and paper towels, and duct tape. What we found was that the majority of families who participated lived in pre-1970 homes and identified as being Black non-Hispanic. Most families reported that the program addressed their concerns, gave them actionable resources, and helped them identify lead sources of exposure in the home. And then a majority of the patients enrolled actually experienced a decrease in lead level of at least 20% on repeat testing. I'm currently wrapping up a similar version of this pilot program in Philadelphia, but I'm focusing really on primary prevention. So most of the children are newborn kids and kids with levels under 3.5. And we're doing these virtual home inspections. We're providing families with lead kits, and we're doing a lot of really specific education based on what we're finding. And then with the hope of these children not being lead exposed at all. And we're beginning to see really great results with this and hope to expand it beyond CHOP South Philadelphia. So with that, I am out of time. Here are my references, and hopefully we have a couple of minutes for questions. Thank you so much.
Thank you so much, Dr. Buncher, for that insightful presentation. Many great questions and answers throughout your presentation. I was checking out the chat. However, we will now open the chat and Q&A for any additional questions. There was a question about the telemedicine initiative and if it's expanded anywhere else other than Boston.
Muted. So the Boston project is ended. And I'm just wrapping up the project in Philadelphia. It's a small pilot project. I think that this is something that I imagine being much more broad and integrating with local public health departments, but that's not yet happening. But I would like to see it happen. Okay.
All righty. There is another question regarding, I'm going to read it. It is it's surrounding code inspections. They would like to know, do you see any code enforcement, proactive rental inspections for lead hazards as an important piece of more comprehensive preventative approaches?
Love this question. And I'm fascinated by it. So the city of Philadelphia has slowly integrated a law in this county that says that any landlord who is renting a home that is built before 1978 has to have it lead certified. So somebody has to come to the home and inspect it and can either say that it's lead certified, or if not, recommend abatement, and then it has to undergo abatement and then re-inspection. So that is the law throughout Philadelphia County. There's a public database in Philadelphia with all of the home addresses and whether the homes are lead certified or not. And I will tell you that of the 50 or so patients that I enrolled in my pilot project, of those that lived in Philadelphia County and were renting, 55% of those homes were not lead certified. So meaning the landlord, or the certifications were expired. So meaning that the landlord is listed as a landlord, but never had the lead inspection done. I can tell you that I rent a home in South Philadelphia, and my landlord is not even listed as a landlord. And so therefore the home has never been inspected because they bypassed the law because they're not technically landlords, and so therefore don't need the inspection. So I think that 55% that I'm seeing in my study is probably much higher, but it's a fascinating question. And I don't think, and I don't think in this, I think it's a step in the right direction, but a lot of landlords are slipping under the radar. Yeah.
Okay, perfect. I know you have to leave at 11, so we have two more questions. The other question, someone wanted the QR code again that you shared. And then the other question is pertaining to the blood levels in newborns and how that relates to their mother's blood level and advocating for screening as it relates to pregnant women.
So for pregnant women, the recommendation is to, again, issue a screening questionnaire for lead risk, and then obtaining a lead level in a pregnant woman if she is at high risk for lead exposure. I think I don't have the data to back this up, but I believe the data does bear this out, which is that very few OBs are actually both screening and testing for lead. And so, yeah, so the fetus is potentially at risk here for sure. And yeah, there's a lot of work that needs to be done in terms of educating OBs on the importance of this, and advocating for higher rates of screening pregnant mothers.
Okay, and then the last question is, has the Pediatric Environmental Health Specialty Unit spoken out in favor of universal blood lead testing and code enforcement, proactive rental inspections?
Hey, so I'm not sure. We'd have to look at the website together. I'm not sure how much advocacy work the Pediatric Environmental Health Specialty Unit has done. I know that the American Academy of Pediatrics has done some advocacy work on this. I know that there's legislation being discussed in Pennsylvania about universal testing throughout the city and throughout the state. But I'm not sure specifically about the PESU. I think that's something that I could potentially, talk to them about and advocate for.
Okay, perfect. Okay, and Dr. Buncher, I know we have to let you go at 11. On behalf of everyone, we just want to thank you so much for an amazing presentation. And before we